Welcome to Urogynecology and Pelvic Healthcare. This is Dr. Mohini Agrawal and today we'll be discussing rectovaginal fistula and fecal incontinence. Does fecal incontinence coexist with rectovaginal fistula? Do rectovaginal fistula manifest as fecal incontinence? So let's see the relation between today rectovaginal fistula and the fecal incontinence. So fistula, for that matter, it's an abnormal communication between two cavities. So rectovaginal fistula is the communication between rectum and the vagina. So that is rectovaginal fistula, and it's usually above the dentate line, and if it's below the dentate line, then it's called as anovaginal fistula if it's less than 3 cm from the anal verge. Colovaginal fistula, this is fistula between the colon and the vagina. It's high. It is also called as high rectovaginal fistula or the complex rectovaginal fistula. That is the colovaginal fistula. And there is one more term in this, that is fistula in ano. That is totally different concept than RVF, anovaginal fistula. Fistula in ano is the abnormal communication between the epithelial portion of the anal canal and the perianal skin. So ये बाहर की तरफ से होता है, that is fistula. That is we are not concerned today with that. So we'll discussing rectovaginal fistula and the fecal incontinence. So according to the location, it's low, medium and high. Low, below, highs, above, higher is there, and middle it's a between. For practical purposes, remember below the cervix, below the ischial spine, that is amenable or that is approachable through the transvaginal route for the repair. Okay, below the ischial spine or below the cervix, okay, that you can easily repair it with very good outcome results from the transvaginal below end. Okay, so what are the causes of rectovaginal fistula? So the most common cause is obstetric. Majority of the cases of RVF is post delivery. It may be vaginal or any instrumental delivery, forceps or a cup, vacuum cup, or episiotomy, iatrogenic injury may be there, or there may be prolonged labor which may lead to this. Obstructed labor. Nowadays the obstructed labor cases are very reduced because of very good services and early referral. So we don't see the typical obstructed labor. Yes, but birth weight, if the baby birth weight is heavy, more than 3.5 kg, 4 kg, then it may again have the chances to cause damage to the perineum and it may lead to rectovaginal fistula. That's the OBS cases. It may manifest immediate, just when you are delivering you may notice that it may be there because of the injury or the iatrogenic or because of the labor process, it may be there, or it may be a delayed manifestation with few days to few weeks also after delivery. The rectovaginal fistula may manifest as fistula. Other causes, post rectocele repair. Yes, when you are repairing the rectocele, you may get post rectocele, there may be cases of rectovaginal fistula. Bartholin cyst repair. Yes. Traumatic from very old, means we have seen even kids, 2-3 साल के बच्चे post traumatic, some object they may be there, they may have recto, and even to the old age also you have the traumatic. Post coital injury may manifest as rectovaginal fistula in just newly married couples. Post coital injury is there, and that they may present as rectovaginal fistula. Carcinomas, because of the cancer itself or because of the radiation, chemotherapy, it may manifest same immediate during the disease process or after years after receiving after the radio chemotherapy, months to years, it may manifest as rectovaginal fistula. So this, apart from this, there is one more category, congenital trauma, foreign body we have seen. One is the congenital anorectal anomalies. Many 2 to 3 anomalies may coexist or there may be something congenital, that is also different, totally seen. It's not very common, yes, but in that subgroup it's a common. So that may be also one of the cause of rectovaginal fistula. Now the symptoms. What the patient presented as symptom. Rectovaginal fistula is there, but what the complaints, what the patient क्या complain करके आएगा, what the patient says to us. The typical complaint is passing of stool, feces through the vagina. Now it all depends upon the size of the fistula. If it's good enough to let the stool solid content to come into vagina, it may be the feces. It may be small, so the patient, while the episodes of diarrhea, the loose stool, only at that time when it's small RVF, the patient, whenever the patient have the diarrhea episodes, then only the liquid stools comes through the vagina and the patient will. It may be again very small, so only the patient may have the flatus, complaint of flatus passing through vagina. That is flatus, when the patient may have the complaint very small, fistula may be there and the patient may have complaint of gas coming through the vagina, that is complaint as flatus. So patient may have the complaint of flatus passing through the vagina. So that depends upon the size of the fistula, the patient have this one thing very common complaint. Now, apart from that, like today's topic, rectovaginal fistula and the fecal incontinence. In urogyne, it's always about the leading questions. So here also you have to ask for the fecal incontinence. The most common cause of RVS, injury, obstetric injury, delivery is the most common cause. So during the process of labor, delivery, there occurs the damage to the sphincters. Okay, and it may go many times unnoticed. That may be occult sphincteric injury. So whenever a patient comes of rectovaginal fistula, you have to ask the leading question for the fecal incontinence, as we ask in the urinary incontinence. Like they have the sensation to go to the feces. When the sensation, are they able to hold? In feces, usually for defecation, we say like patient should be able to hold for minimum 15 to 20 minutes when the sensation to pass the bowel is there. To pass the feces is there, so that sensation is there, so she should be able to hold for 15 to 20. So if the patient is having fecal urgency, it may be associated with leakage or not associated. Remember, somewhat difference with urinary, it's same like an overactive bladder. The patient may have the fecal urgency. जैसे urinary urgency होती है वैसे ही fecal urgency. Difference what होता है, urinary you go many times in the day, so patient may be outside somewhere, some other task. So whenever she have the urinary complaint, that is also delayed. मतलब patient seek the delayed help in the urinary problems also. But in fecal incontinence, again it's very delayed. Reason, feces usually it's once in the morning. That was the morning time, and whenever females get up early in the house, so whenever she get up, the washroom is usually nobody or it's not occupied, so she rush and she managed to do it. She is not able to hold till 15-20, but उसको कभी इतना time जरूरत ही नहीं पड़ी कि वो hold करे. But if this chances occurs like in diarrhea or some other, so I want to say like chronic RVF also persists. Many patients has the RVF for small RVF for many years, but diarrhea once in a while होता है, so they are not bothered or concerned, and उसके साथ fecal incontinence the patient usually manages to go. So whenever a patient comes to RVF, take that opportunity to ask whether she is having associated fecal incontinence with that. So this is the leading question. First, your fecal urgency, it is associated with leakage or not. So passive fecal incontinence, flatus incontinence, this all should be asked to know the function of the sphincter. So if required with RVF only, we can do sphincteroplasty. Okay, so this is the symptom, very common. First, other symptoms the patient may have: dyspareunia, perianal pain, because obviously always the stool is in contact with the perianal skin. It's very irritating. The excoriation of the skin may be there, fibrosis may there may be pain, there may be pus, bleeding, there may be repeated vaginal infection, repeated urinary tract infection, small RVF unmissed, the patient is having repeated urinary tract infection. We always know whenever there is urinary complaint, we go detail for the bowel complaint, and whenever the patient is having some bowel complaint, usually UTI is the common association. So vaginal infection, genitourinary infection, so these are the common one of the presentation the patient may manifest of rectal vaginal fistula. So the causes and symptoms, we come to now for the examination. How you examine the patient, or what are the specific? Directly coming to the local examination, specific in rectovaginal fistula inspection, patient is lying down, dorsal position. So whenever you see inspection, there may be soiling of the perineum area, there may be soiling, you see the fistula may be visible to you. You always look for the perineal body also. What is the, means like by seeing only whether it's present, absent, and roughly what is the estimate. So before proceeding, after the causes and symptoms, before proceeding for examination, causes even inflammatory bowel diseases like Crohn's disease. It may present as multiple fistula. Multiple fistula may be there. Pessary. Pessary does not cause rectovaginal fistula, but the neglected pessary for years. So ring pessary or the Gellhorn pessary, when the neglected pessary for years, then it may cause the rectovaginal fistula. Now examination. Before, let's see a case. I will say a case presentation. So there is a case presentation. A 29-year-old female, para to live true, both the normal. The last delivery was on 2nd of Feb 2024 with birth weight of 4 kg. The para one, live one, the last previous delivery was 3 years back, with it was a hospital vaginal supervised delivery with birth weight of 3.8 kg. Now after first delivery, patient had the complaint of fecal urgency, but it was not associated with fecal leakage. As I just said that many patients have just fecal urgency, but it is not, incontinence is not there, feces does not is on leakage, except when diarrhea occurs. Okay. Then after second delivery, the patient present with passage of flatters, feces through vagina, and also with fecal urgency associated with leakage. So this was the case scenario. Means I just want to signify कि para 1 उसके बाद ही उसको था, but after the second delivery now she is having the rectovaginal fistula also. That's the typical complaint. Through vagina there is a passage of flatus and feces. So workup, when this patient come, what you do the workup? Very first, in RVF there is no specific list of investigation you do, बहुत सारी चीजें नहीं है, just you do the examination. It will give you a lot of the idea. A syringe test that I will show how you will do it, syringe test, and one the transperineal ultrasound. Introital ultrasound is something which you need to do if here all the scenario which topic we have discussed, the rectovaginal fistula and the fecal incontinence. What happens? Perineal body is intact. See, there is occult sphincter injury usually in the majority of cases. जब भी RVF होता है after OPS causes, there is some of the amount of the sphincter damage. So what happens is you repair the RVF, you close the tract and it's healing. But RVF repair does not guarantee fecal continence. Yes, RVF repair will not treat the fecal continence. So for fecal incontinence she is having. So if you see the perineal body is intact, so test how you do it, how you see whether the sphincter is intact. That is a transperineal ultrasound. In transperineal, I'll explain later. So you do it for the sphincter, if the damage is there, to see the extent of damage, to see the edges, because in the sphincteric damage, perineal tear also, if you see, the edges get retracted. So okay, so this is very important to decide the type of surgery. So if RVF hai, you can just close the trachea. But if RVF is along with the complete perineal tear, then you have to convert the RVF into the 4-degree perineal tear and repair. Now management, how we do with the management. So we in this cases, if you can clearly see, there is an artery in the fistula tract and perineal body के नाम पे कुछ नहीं है, धोखा है, बस बिल्कुल छोटा सा skin tag है. That's why only when you do the examination is everything. So in this case you neither is just only examination, even syringe test is not required, because artery through and through is going very nicely. You can see the defect with the doing your finger parectally also, you can have the defect. So there is no need for the syringe test or the scan in this case. Okay, it's an RVF, but we just converted that perineal body cut, converted into 4-degree perineal tear, and we repaired it under the spinal anesthesia. So end-to-end repair was done. So this is the post-op pic. This is the posterior perineal body of 2 to 2.5 so approximately is made. So this is done with the case. So examination. Now after this was only the case. That's only I'm trying to say the rectovaginal fistula. Usually it's associated with complete perineal tear. So in this case we saw, मतलब para 1 line पहले से उसको fecal urgency थी, इस बार उसको RVF हुआ. RVF के the patient came with the passage of fecals, but on history she said obviously fecal urgency पहले से भी थी, and now it has been worsened because it's quite a huge. But if it have been small, perineal body puri intact, and this was just 0.5 centimeter from the anal virgin this way in introitus. If suppose 1 to 2 centimeter behind, and if the perineal body, so you have to detect the occult sphincter injury. That is very important. क्योंकि अगर RVF के साथ fecal incontinence है, then you have to change the modality of the surgery. You can just repair the RVF as a tract also, but you have to do sphincteroplasty also. This is one technique. Second is RVF converted into 4th-degree perineal tear, and you do completely stitch it. So anyways you can do it. So that's why fecal incontinence, knowing whether it is having or not, that is the utmost important. So examination. There is a fecal swelling usually when the patient comes. So you take a wet gauze piece, wet gauze, and you clean with the saline. Don't use betadine. I'll tell you why. Just you clean with the clear of the feces, and you see location where it is, low, mid, high, number of fistula, what is the margin, fibrose, pus head, discharge, granulation, fibrosis, puckering, tissues, how it is healthy or supple, margin fibrous hair, tissue is fibrosis, blood supply, how you feel it's healthy or unhealthy, the tissues. So this basically point you see with this. You do a per rectal examination obviously, and per rectal examination from there, and the per vaginal examination to see the fistula thickness and edges and margins, edges of the fistula. Now when it is big, it's very clear cut, you don't need anything, but you cases are of different types. So what happens when अगर clear cut नहीं है, तुम देख रहे हो but you are not able to find it correctly, so what you can do is you can do a probe test. बहुत thin सा probe, you can insert it from either from the anal canal side or from the vaginal to see the tract and where it opens. Sometimes you may be able to find the vaginal opening पर anal opening नहीं मिलती. कभी कभी most of the times you find the anal opening but you don't know where it is opening in the vagina. So you can do the probe test. That is the probe test. Now second, which I said in this case presentation also, syringe test. This you should do very commonly. So what is that? With the probe also, even if you see the openings both the in the vagina, sometimes the probe you are not able to negotiate. Why? Because the tract might be oblique. So at that time, if you're not able to probe it or you're not able to find with the probe, or it's very small, you don't know from where the patient, मतलब है भी fistula नहीं, patient is complaining or something pus coming from vagina or something flatus coming from the vagina, gas is coming, but you are not able to see anything, and so how बहुत छोटा है, so it may be missed. What you can do, you take a 10 cc syringe and 2 बूंद betadine के, just 2 drops of betadine, you dilute it into a 10 cc syringe with lot of lignocaine jelly, because obviously PR you will put that, so it will be painful. So a lot of lignocaine jelly on the 10 cc syringe, betadine diluted in the 10 ml syringe, filled with normal water, distilled water, normal saline, okay, and you just push and just keep a small gauze. That's why I said initially don't clean with betadine. तुम्हें पता ही नहीं चलेगा betadine से clean हुआ तो ये करके, because you are using betadine. So it's easily you can just do in a UPD also, मतलब very simple at the handy test. You put a gauze paste, don't put a mop, क्योंकि mop से कहाँ हो जाएगा पूरा पता नहीं चलेगा, या pad भी बड़ा नहीं, just a single gauze paste you just put in the vagina and give a pressure. If not 10 cc you feel the pressure is not there or you're not able to, you can do the 20 cc also. So you just push it from the anal canal side, anus side, and if there is a fistula it will come on the vagina. So this is very simple test, by syringe test you can detect if any patient complains of flatus incontinence, because अगर liquid stool passage है, containing है and solid, so usually it is big and you are able to see it with the naked eye. Okay, so this is the one thing. And obviously while you do the syringe test, keep anterior speculum retracted to see the posterior vaginal wall. So you have to put the speculum in the anterior side. So not go to the very basic. So this is the syringe test. Now with this, very important in examination is perineal body. Again repeatedly in RVF, fecal continence patient है कि नहीं है, this is very important. So you have seen the perineal, see जब defect है in this case, like as we saw, perineal body ना बराबर थी 0.5 centimeter, but when there is a perineal body intact, you see it's not good to put 2 to 2.5 centimeter perineal body, but when you palpate it, you feel it, you roll it, you reverse roll it, you see just a skin tag, there is no sphincter in it. So you may suspect, yes, she may have some amount of sphincter defect, because all patients will not complain of fecal urgency. Even if you ask, उनको होगी भी, but they may feel that this is not, मतलब important, that is not a problem. You just focus on this problem, that I'm having passage of stool from vagina, I'm able to control. वो नहीं भी हुआ तो चलेगा, but the patient don't know what is the significance and all. So कभी-कभी patient accept भी नहीं करता. So if you feel the perineal body is not good enough for you, then you suspect the sphincteric injury. Now with this, you ask even patient to squeeze the, see even in RVF or even in the complete perineal tear, पूरा perineum गया हुआ है 4 degree perineal tear, but still if you tell them to squeeze, you can see that rugi marks of the external sphincter. So the patient is able to squeeze or not. तो वो RVF में भी you try to step and feel whether this patient is able to contract, so you know some idea of the strength of the sphincter with the patient. Now in few cases, patient when you are asked to squeeze, there is very poor anal tone, because this patient, it may be chronic RVF also, just as I said, postmenopausal or after the time, so there may be, मतलब इतनी strength नहीं होगी उसमें, there may be lax spatulous anal canal, or there may be associated mucosal prolapse, rectal prolapse, anal prolapse, mucosal prolapse of the anal area. So this is there. So you need to see, because one is the sphincter injury, because of which the fecal incontinence will be there. If you have seen in many cases, even after the repair of the sphincter, there is fecal incontinence. Sphincter is repaired very nicely, even you confirm it by scan, but still there has a patient of fecal incontinence, and that is due to pregnancy itself is a risk factor for pudendal nerve injury. Pregnancy itself, labor again is a different story, it's labor to ho hi jata hai risk factor, the pregnancy itself. So what happens is that pudendal nerve injury may also lead to fecal incontinence. So rectovaginal fistula, check for the perineal body, check for the sensation, check for the strength, whether the patient is able to contract, squeeze it. If there is sphincter injury, we definitely will do the sphincteroplasty. But after sphincteroplasty, if the patient persists, then we can go for tibial nerve stimulation or the sacroneuromodulation. For pudendal nerve, checking whether it's intact or not, you can do pudendal nerve terminal latency test is there, but it's not very reliable, so we don't do. So this for pudendal nerve checking or the local, you see the perineal body, and the squeeze is very important. When you do all this, with this obviously we are doing the per rectal specific to rectovagina, but we'll definitely do the PS, we see for the cervix, vagina and the uterus and everything, that is the routine. But when you do all this, in the old case, when the patient is old, postmenopausal, or you're not, it's not an acute RVF you're seeing in the lid, specifically see for prolapse with the patient to have an associated rectocele. So your surgery, incision, that you can plan it that way. Rectocele, cystocele is there, or any other prolapse is there simultaneously. So you can, like we have a case, I have seen a case, a patient came with post-hysterectomy VVF. When we examined, the patient was having RVF also. But like we asked, Miss RVF hai, but patient did not give any complaint answer. So she said, but I'm not bothered by, you just do the VVF repair, because it was leaking, because VVF that she used to diaper and no continuous void was there, no self void was there. So continuous leaking was there. Means patient has the complaint, but they just get adapted it because it's small. Because in symptoms also, many times patient, if there is a small RVF, patient may be totally asymptomatic. So that it depends upon the stages. It's not like fixed and yehi symptom rahega, itne centimeter ka hai, so it will present at like this and this hai, to aisa. Okay? So this is the thing. So whenever you ask the patient or examine the patient, you look, when it's old case, you look thoroughly whether she has perineal tear. Many patient comes old age with prolapse and with perineal tear. Perineal body nahi hai, but they are bothered with prolapse. So whenever obviously patient is subjecting the anesthesia and the surgery, so we can simultaneously repair at the same setting the perineal tear also. So this was the examination. So in examination, when you do all this, even you see for the vaginal length. कभी-कभी RVF में repeat RVF repair, recurrent RVF, failed previous RVF, or it may be a huge. This one also almost 2 by 2 centimeter, बड़ा था ये, पर मतलब they may be 3. So vaginal length also gets shortened. So or you may feel that the healing may compromise, so you may add the Marsh's flap also with that, any flap tissue for that. So that's why the length also you see, means how much length of the vagina is affected by RVF. That is also one of the important consideration. Okay, because some RVF is like deep, मतलब अच्छा बड़ा होता है till the cervix. So obviously vaginal length may also have some role in it.